Thank you, Professor Satish, and it's lovely to see so many people here. Just to reiterate that at the end of the question and answer session that we will have after my lecture, we have the opportunity to not just have coffee but a group photograph. This symposium has been given 5 credit hours by Tamil Nadu MGR Medical University. So at the end of the oration, people can pick up their certificates as well as they leave. So just 2 housekeeping announcements before we begin. I'm going to talk to you about integrated care for epilepsy. Just to reiterate that epilepsy is the most common serious neurological condition. It affects 5 to 10 per 1,000 people in the community. It's estimated that over 50 million people with epilepsy live worldwide, and about 10% of them live in this country. Thanks to the many developments in medical science, epilepsy is eminently treatable. What we must know is that treatment of epilepsy includes medication, anti-epileptic drugs, which you've heard a lot about. It also includes surgery in intractable cases, brain stimulation procedures, and the one aspect that many people forget is that it also includes psychosocial interventions, and that's something that I'll focus on a little bit during the course of this talk. This is a paper that came in the journal Neurology in the year 2000, and Professor Pedley, who is here, did write an editorial that went along with the paper called The Scarlet E. The Scarlet Letter was a novel written about 2 centuries ago, which talked about branding people and stigmatizing them in the context of a relationship. But here, using the word Scarlet E is how people with epilepsy get stigmatized, and that's really what the paper was talking about. They reviewed 210 media stories, and they found that about a third of them had inaccuracies about epilepsy. Wrong information in 14%, unrealistic expectations of new treatments in 9%, and exaggeration of seizure risks in 5%. And I think it's very important to remember that people with epilepsy end up having their lives limited, end up having fewer opportunities, partly because of this stigma. And we must keep in mind, therefore, that the stigma needs to be addressed all the time when we are treating a person with epilepsy. I'm going to talk a lot about a patient as an example of why integrated care is required. This is a girl who's now a teenager, still follows up with us, was 6 years old when we first met her. She was second of 2 children in a middle-income household, both parents being working professionals. She had a normal childhood and early developmental period. There was nothing to suggest that she had any developmental problems before she presented with these seizures. She lived in close proximity to one set of grandparents, the maternal grandparents, who were her caregivers. Both parents were working, they worked long hours, and the child was looked after by the grandparents. Pre-morbidly, before she started having these attacks, she was intelligent, she was interactive, she was a willing participant in many extracurricular events, she was learning to dance. She had a proneness, however, for attention-seeking behavior, and she was prone to throwing temper tantrums, especially if she participated in something and did not win. So she had an intrinsic need to win. That was very important to her. But none of these problems were of a nature or quantum that ever had needed the family to seek professional intervention. These were things that came out in the history when we started asking how was she before she started having these events. Initially, these were thought to be psychiatric, and it took quite some time for us to understand that they were not psychiatric. When I say quite some time, it's only when they came to us after 2 or 3 other consultations that we actually picked up the possibility that these were seizures, and that too happened when the father gave me a mobile recording of what was happening. I told him, please try and record a seizure, an event, and show it to me. And sure enough, it clearly did appear to be a seizure. I can't show the video because we are talking about a young girl, and this is a multidisciplinary audience, so I'm choosing not to show the video. In one event, she used to jump up and down about 20 times while sitting, clapping hands and laughing being part of that episode. And these lasted a couple of minutes, were associated with sweating, and she appeared, however, to be partially aware, and towards the end of that episode could actually answer questions. The episodes tended to terminate with a cough. The other happened while sleeping, and this is really the one that we have a video of, where she appears to rouse suddenly, stare, and then move her hips and legs up and down 5 to 10 times rhythmically. It's followed by a smile, hyperventilation, and then incomprehensible blabbering for a few minutes, following which she would go back to sleep. The episode could repeatedly occur on certain nights, and initially it was reported that she would respond to a call during the episode. Later, she stopped responding to calls, became unresponsive right through. Before she saw us, she was having episodes that occurred both during sleep and wakefulness, but by the time we saw her, she was having only the sleep time episodes. And the nocturnal episodes were longer, lasting as long as 2 minutes, fewer, starting at about 11 p.m., an hour after she started sleeping. And in the afternoon, she had 5 to 6 1-minute episodes, all within an hour during her sleep. She would come back from school, have her meal, go to sleep, and then she would have these episodes. Bedwetting occurred once in 2 days and only at night. So we proceeded to evaluate her fairly thoroughly, and at that time we did not have access to video EEG telemetry. I'm talking about several years ago now. So we found she had no stigmata or focal deficit suggesting a developmental disorder, although she was slightly obese and clumsy. She had normal serial MRIs, and we had a 3 Tesla MRI done. Once again, we were talking about 3 Tesla about 9 years ago. And at that time, we did not identify either hippocampal sclerosis or cortical malformations or anything else to indicate why she was having these seizures. She had normal hematological, biochemical, endocrinal, metabolic, infectious, and inflammatory parameters. So she was looked at very thoroughly to see if there was a reason why she suddenly started, a biological reason why she suddenly started having these episodes. And her EEGs were abnormal with bilateral spike and wave dysfunction, but she did not have any specific localization or lateralization. And I'm talking about prolonged EEG monitoring, but not about video EEG telemetry. Our clinical psychologist saw her using a range of tools to assess intellect, to assess specific learning disability, for neuropsychological evaluation, and to assess attitudes towards various circumstances. We found that she had inattention, verbosity, and playfulness, and all this prevented her from completing her evaluation properly with the clinical psychologist. She was found to be bright normal in terms of intellectual ability with an IQ of 119 with mild dysgraphia and dyscalculia. So she had mild learning disability. On projective testing, fighting with a friend, problems at school, and a fear of ghosts came up. But there wasn't anything very striking to suggest that there was a traumatic event that had happened, psychologically traumatic event that had happened to cause these episodes. And on neuropsychological testing, she had problems with working memory, comprehension, attention, and visuospatial ability. So in a sense, her entire psychological profile indicated that she was likely to have problems with the frontal lobes, the front of the brain. And her verbosity, inattention, and playfulness in particular indicated this. The video that we saw of the nocturnal episodes that she probably had frontal lobe seizures. This was also corroborated. At that time, we had Professor Stephen Schachter visiting us, and he saw the child, he saw the video, we discussed, showed him the EEGs, we discussed the patient with him, and he agreed that she had epilepsy, she probably had frontal lobe epilepsy, she might have one other type of epilepsy as well, because all the episodes were not explained by a frontal lobe event. And when the behavior therapist saw her, she recorded that there was a distinct change in her behavior that had taken place. In recent times, she was hyperactive, aggressive, she could be abusive, bite or spit, she could be to eat excessively, and the eating was disorderly. This is a very specific frontal lobe sign. It's actually seen in people with frontal lobe dementia. It's well described by experts in the area, and it's eating as if there is no tomorrow. There's a very odd and different pattern of eating which is not usually seen in the person. She had started bullying other children. She could lie and participate in overtly manipulative behaviors, and she had taken to challenging authority figures. So there seemed to be a change in mood and demeanor that accompanied the events that she was happening. So when you do a biopsychosocial formulation for her, from the biological perspective, she had frontal lobe seizures, perhaps other types of seizures. There was perhaps an undetected biological trigger. We did not find one, but that does not mean that there wasn't one. She had underlying learning disability, and this we felt was posing difficulties for her as she tried to go up the academic ladder, and that was something that could have been provoking problems for her. She had the need for success and a kind of a winner's instinct, and not necessarily the capacity to produce those results. And the family had high expectations of her and a need for achievement, because she's a very gregarious girl who would come across very well to people when she spoke to them. So she was started on levetiracetam and clobazam for seizure control, and for behavioral control, we gave her risperidone in small doses. She also started to receive a multidisciplinary intervention, which included behavior therapy, remedial education, and family counseling, neurodevelopmental and task-based occupational therapy with focus on attention, fine motor skills, and handwriting, and remedial education support after school for her dysgraphia and dyscalculia. But that typically in a child with any neurodevelopmental disorder, not just epilepsy, is not enough. One needs to work with all the other elements that form a child's life. The most important of those being school. Very often schools don't understand what the child is going through. And what we need to do is actually draw out with them what's called a statement of special needs. What are the challenges that this child faces, and how can we together help this child? We don't do statementing automatically in India, but statementing is a very important part of for doctors working together with schools in order to ensure the child actually stays in school. So we did that. And then we built a therapeutic alliance with her parents. I think everyone who practices in India knows how difficult it is to, when response to treatment is slow, to ensure that the patient continues in the treatment program. They usually go off in search of other cures. So it's very, very important that we build a therapeutic alliance with the family, with the person, and convince them about the importance of staying on the path and not straying from the path. And of course, we developed a process of continued and consistent communication between the family, the school, and the team. All this requires interventions from either a social worker or a psychologist, and this is not the work that a doctor can do alone. It actually is the work of a multidisciplinary team. And when we talk about integrated care, that's really what we are talking about, that it's important we work as a team and not as individuals. Over weeks of treatment, her seizure episodes stopped, her behaviors became more manageable. Her problems with inattention, learning, and academic performance did, however, continued, and she continued to attend through this period our after-school program, therapy program for all the things that I mentioned. We've now seen her for 9 years. She's now on AED monotherapy, and I've started tapering levetiracetam because she's been seizure-free for a considerable period of time. She's off risperidone for many years now. She remains clinically stable. She's euthymic. There are no significantly abnormal behaviors. She does have the usual teenage issues, but that's not abnormal by itself. She has moved into an open school system because over time we found she simply wasn't coping with the mainstream school. So she's now in the national open school system that allows her to take exams flexibly, and that actually has brought down her stress considerably. And her family remains fully supportive of her, and there are close ties. Their expectations are far more modified, and they are both able to deal mutually with their expectations. So beyond seizure control, we must, in epilepsy, for our people with epilepsy whom we look after, emphasize on role functioning. And in a child, it's educational functioning. In an adult, it's occupational functioning. We must emphasize on family functioning, and if the person is married, on marital functioning. We run into problems several times. We must look after their physical health and nutrition. We must remember that most people with epilepsy or on anti-epileptic drugs can have poor liver health, poor bone health. These things need to be monitored. And very importantly, we must look after their psychological functioning and work with them to ensure that they have happy, holistic lives. So we can intervene at many points: education, special classrooms, jobs, by skilling people with epilepsy; society, by encouraging them to participate actively in social activities. Many people are kept closeted at home. Relationships, by encouraging transparency and interaction with others. And finance, by taking opportunities with all the different schemes that are available to us through the government. And what we must look at are multidisciplinary models of care that include, apart from the doctor, psychologists, social workers, physical therapists. There needs to be a kind of a paradigm, and we've published this in Epilepsy and Behavior some years ago as a best practice model. And in TriMed, what we do tend to do is make it very holistic, bringing in, apart from all these treatments, we bring in a whole range of supportive programs for physical and emotional health. And at the moment, TriMed is working with 25 children with autism in school. We are actually taking the care to the special school. And what we are trying to do is to see whether we can actually measure outcomes by giving them structured and graded programs that integrate care. And we hope to see good results with that. What we are seeing preliminary are very good results already. I'd like to finish by quoting a parent of ours. Epilepsy is only one part of an affected person's life, and the doctor is only one part of the affected person's care. Thank you so much.
Thank you.